Ladies and gentlemen, I'm delighted to welcome you to this inaugural lecture, which will be given by Professor Tony Rudd. I am Anne Greenhoff and I'm Head of School of Medicine. Inaugural lectures are to celebrate the highest academic achievements, resulting in the award of a chair by King's College London. Professor Tony Rudd qualified from the University of Cambridge and King's College London. After registrar jobs in medicine and neurology, he went to the Hammersmith as registrar in geriatrics, followed as a lecturer by being a lecturer at St George's Hospital, London. In 1988, he was appointed as geriatrician and general physician at St Thomas Hospital. He took responsibility for the stroke patients a year later. In 1995, I apologise. Sorry, Tony. Oh, you obviously keep youthful as working in stroke. He was invited to the Royal College of Physicians to develop a programme of work on stroke in their research unit. Since then, he has developed and led the National Audits of Stroke, the National Clinical Guidelines for Stroke, and peer review of stroke services. He has also chaired the guidelines development groups at NICE for acute stroke and transient ischemic attacks, as well as medical complications of alcohol. He also chaired the group that developed the NICE stroke quality standards and NICE commissioning outcome indicators. He served as president of the British Association of Stroke Physicians between 2004 and 2006 and helped develop and implement the specialty of stroke medicine. He is a trustee of the Stroke Association and is now one of their vice chairmen. Since 2010, he has been the clinical director for stroke in London, overseeing a major reconfiguration of stroke services. Since April 2013, he has been the National Clinical Director for Stroke for NHS England. His research focuses on stroke epidemiology, the natural history of stroke complications, and quality improvement in stroke. I now invite Professor Rudd to give his inaugural lecture entitled 25 Years of Stroke Care, How Stroke Became a Disease Worth Treating. Professor Rudd.
Thank you very much indeed, Anne, for that introduction. What I hope to do over the next hour is to give you a bit of an overview of how stroke has developed over the last 25 years. I hope that I don't patronise the non-clinical members of the audience, and I hope I don't bore too much my clinical colleagues. It's traditional to start off with a little bit of background about my family and my training, but once I've got over the boring bit, I will then tell you a little bit about what stroke is, where it's come from in terms of the history of stroke, and then something about the research that I've been involved in, both from the point of view of acute care and rehabilitation and prevention. And then at the end, talk a bit about implementation of some of that evidence into practice, both here in the United Kingdom and abroad. So my mother, Erica, who's in the audience, delighted to see her here today. She's going to be 90 this year. My father died about 5 years ago. He was a factory inspector, she was a teacher, and somehow between the two of them, managed to produce, of their 3 children, 3 doctors. My brother, Peter, who's decided he'd rather be on holiday than here, is a paediatrician in Bath, and my sister, who is here, is a palliative care doctor in Leicester. And before any of you say anything, I agree with you entirely. I can't see any family resemblance between myself and them either. So I went up to Cambridge in 1972 and then trained at King's College Hospital, one of our partner organisations now. It certainly wasn't at the time. There was considerable rivalry. And then after house jobs and other junior jobs, I made a decision that I was going to specialise in geriatric medicine. And when I made that decision, the neurology consultant I was working for at the time looked somewhat shocked and made the statement that he thought I could probably do better than that if I wanted to. But nevertheless, I didn't agree with him and went and did a registrar job with Malcolm Hodkinson at the Hammersmith. And at the time, Finbar Martin, who's my senior consultant colleague here at St Thomas's, was the senior registrar. And I learnt a huge amount about geriatrics at that stage. It was the first time I'd really gone into the specialty in depth. And what Malcolm Hodkinson taught me was how important it was to really pay attention to detail and how the diagnosis of disease in older people was really important. And Finbar actually taught me a huge amount at the same time. I then went on to work with Peter Millard at St George's Hospital and as his lecturer, and I spent nearly 5 years there. It was a wonderful time, actually, before the time when trainees had to rotate every 20 minutes between different consultants. I was able to spend almost that entire time as an apprentice to Peter Millard. And he was an inspirational teacher. He taught me many things, but amongst the two which I think are most important were firstly that people take time to recover, and we need to give them that time and not try to rush them through the system too much. And the second thing was about treating people, all people, particularly older people, with dignity. While I was there, I spent quite a bit of time in the laboratory doing some research on immunology in older people, and what that taught me was that I didn't want to spend my life in a laboratory. So I was then appointed as a consultant with Finbar here at St Thomas's, which is where I've remained for the last 25 years, and it's been a very fruitful and enjoyable experience. And I've just put pictures up of two of my key research colleagues, Charles Wolfe and Chris McKevitt, and I will mention their names several times as the lecture goes on in connection with various research that we've done. So what is a stroke? Hopefully most of you know, but for those of you who don't, it's a disturbance of the blood supply to the brain. It's surprising how many people still believe that stroke is a disease of the heart. And it comes in two sorts: a blocked artery leading to death of the brain cells as a result of them not getting the oxygen or the nutrition that they need, or a burst artery which results in blood leaking out into the brain tissue. The end result of those two things is the same, that patients develop very rapidly focal neurological symptoms, usually, with symptoms which relate to the part of the brain that's been damaged, so typically paralysis, loss of language, and so on. And these are pictures illustrating cerebral infarction, typical appearance of the blood clot blocking the artery going to the brain, the post-mortem appearance on the right-hand side of a bit of brain that's died sometime previously and has been resorbed. Another example of the cause of cerebral infarction, which we commonly see, which is the artery taken out of the neck, the carotid artery, which has become clogged up with fatty deposits, atheroma. And on the right-hand side, a brain scan showing a well-established infarct in the right side of this individual's brain, a very profound stroke in this particular individual. And hemorrhage, the other type, which happens in about 15% of patients, showing blood within the left side of the brain and a similar appearance on the CT scan. So that's the disease that we're treating at a pathological level. At a clinical level, it's a major importance, of major importance. About 110,000 people a year in England will have their first stroke, 20 or 30,000 more will have a recurrent stroke. And of the patients who have a stroke, about 20% will die within the first month. About a third will be left significantly disabled, but there are very few people who have a stroke who are not left with some residual problems, even just psychological. I say just psychological, but that's obviously really critical too. And about 5 or 10% of people will end up in long-term nursing home care. It's the third commonest cause of death in this country, and the largest cause of significant acquired adult disability. And it not only therefore has major impact on the individuals who have it, but on society as well. It costs the health service about 2.8 billion a year, and the country overall about 7 to 8 billion pounds a year in terms of the costs of looking after people with disability, in terms of the costs of providing them with nursing home care, loss of earnings, and so on. So anything that we can do to reduce the impact of stroke clearly has to be important. And this is a slide which surprised me when I first saw it. So this is a map of the world showing that stroke in the high-income countries, as I've said, is the third commonest cause of death, but in the low and the middle-income countries is actually the second most common cause of death. So it is a worldwide major significant problem. It has long-term impacts, as I've mentioned, and these are data from patients in the South London Register, 6 months after their stroke, showing this range of sort of physical needs that patients typically have. So needing help with bathing, help with dressing, help with feeding, and so on. But there are also a lot of hidden needs that we don't perhaps recognize frequently enough. And this was a survey funded by the Stroke Association and conducted by Chris McKevitt, looking at the unmet needs of stroke patients. And I just put up a few figures around the deficits in terms of fatigue and concentration and memory and reading, things which actually we might easily miss, very commonly present in lots of other problems too. So stroke has traditionally been a disease for which actually we could do very little. That was the belief. And these are some examples of the sorts of things which have been suggested for preventing stroke and treating stroke in the past. Pandora Pound worked with us. She's a social scientist back in the 1990s and wrote this article, From Apoplexy to Stroke. So she found evidence in the literature that if you want to prevent stroke, you'll avoid extremes of passion, particularly joy. And in fact, there is, of course, a bit of evidence base around that. It is possible to have a stroke or a heart attack when you are getting extremely passionate. And the evidence seems to suggest, may not be very terribly robust, but if you're with your mistress, it's more likely to happen than with your wife. So there's some element of truth there. Don't have a short neck or a big head, and avoid everything the least bit flatulent, and avoid too much indulgence in sleep. And of course, actually, what we know as well is that people with sleep disturbance, who often do have short, fat necks and are very sleepy during the day, are also at increased risk of stroke. In terms of treating stroke, I'm not aware of any randomized controlled trials which have tested any of these, so we don't know whether they work or not. So maybe these are ideas for some of our students to do some trials on, particularly, I thought, the stimulating enemas. And in terms of the recurrence of stroke, what's been written about that? Well, Napoleon's physician wrote this, that a first attack is often slight, is a summons without cost, a second a summons with costs, but a third is an execution on the person. That is not strictly true, but what amused me was I was going over Westminster Bridge after Princess Margaret had had her third stroke to go and give an interview to the BBC, and I got a phone call from the producer who said to me on the phone, I particularly liked the statement that you made to our researcher, 3 strokes and you're out. And we'd very much like you to use that in the interview. Of course, I'd said nothing of the sort and didn't say it. And this is the other quote from relating to Napoleon that I put in because it bears no relevance whatsoever to the talk, really. But I did like the idea that his custodian thought that stroke was not a tedious disease, but many of the others were. I'd much rather he die of a tedious disease, which our physicians could properly declare to be natural. And William Osler, at the end of the 19th century, wrote about stroke that it is the duty of the physician to explain to the patient or to his friends that the condition is past relief, that medicines and electricity will do no good, and there's no possible hope of cure. And to be honest, that was the sort of situation which we had when I first started as a physician at St Thomas's. Now, this picture was taken maybe a year or two before I started, although Anne Greenough would perhaps not have you believe that. So the patients were nursed in beds very much like this, in Nightingale-style wards, and indeed, when I started, the nurses did indeed dress properly and have proper hats on. Patients were admitted under the care of any one of the general physicians working in the hospital, any one of the medical wards, 15 wards potentially. Very little happened to the patient acutely. They were admitted, they were clerked, they were probably taught on once or twice, and then they lay in bed waiting for the geriatricians to take their care over for rehabilitation, and for many of those patients, unfortunately, it was quite a long wait. There was no specialist stroke service either in the hospital or in the community. Getting even basic investigations was very difficult. Brain scans, for example, were difficult to obtain and therefore rarely done. And an anecdote that some of you may have heard before, I think is worth repeating. So I had recently started as a stroke physician, as a physician here, and I wanted a scan on this particular patient. There was a good reason why I wanted a scan. We sent the form down requesting the radiology department to provide one. And 2 days later, which was the speed that the radiology department worked in those days, the request form came back, scribbled across it, scan not indicated. So I sent my registrar down to explain in a bit more detail why a scan was necessary. He came back half an hour later, a bit sheepish, said, "I'm sorry, I just can't persuade him." So I thought I'd go down and have a man-to-man chat. I went into his office. He stood up, he looked a bit angry. He said, "I've already told you you're not having a scan on this patient," and he thumped me in the face with his fist. Now, that is the only time I've ever been hit by a fellow consultant. It's not happened since, not even by a radiologist, which tells me that services for stroke patients have definitely improved. If you look at the results in terms of outcomes for stroke, back in the mid-1990s, there's clear evidence that we were underperforming in the United Kingdom. These are data from a big trial that was conducted testing whether aspirin acutely after stroke was beneficial or not. So 20,000 patients recruited from many countries around the world. And if you just look at the bottom set of data, anything over to the left-hand side of that vertical dotted line, the outcomes in that country were better than average in terms of death or dependency. Anything to the right-hand side, worse. And these countries down here, you're probably too small to read, but Sweden, Argentina, which was in the middle of a financial crisis at the time, Poland, Australia, Italy, all doing really rather well. And here was the United Kingdom down there with very significantly worse outcomes. And Charles Wolfe led a project that I was involved in, again in the mid-1990s, comparing the way that stroke care was treated in different European countries and looking to see what impact those differences in treatment had on outcome and also in terms of the cost of care. And it was a fantastic natural experiment because there were very, very clear differences. So in Budapest, the hospital which I visited, 90 patients in one ward, general medical ward, 3 nurses looking after the patients with a few conscientious objectors. In London, I've described already, lots of rehabilitation. People stayed in quite a long time, but very little happened to them in the acute phase. In Germany, people would be rushed into a neuro-intensive care unit, have lots of scans on their brains, on their carotid arteries. In Italy, for example, no speech and language therapy or occupational therapy. So lots and lots of differences. What was the outcome of the study? Well, summarized many years' work that Charles did in one slide. The vertical bars in blue are the relative costs adjusted for the cost of living index in the various countries against the base country, which was Latvia, the cheapest. So in Denmark, they were spending about $8,000 more per stroke patient than in Latvia. And then the dots with the confidence intervals attached to them are the hazard ratios for poor outcome. And what you can see is that over on the left-hand side, if you spend very little on your stroke patients, your outcomes tend to be rather poor. If you spend a lot up at this end, it would appear in Finland and Denmark, you have much better outcomes. But here was London, we're spending a lot of money, and yet our outcomes were really no different to those in the low-spending countries. So again, a message suggesting that whatever it was we were doing with our stroke patients was not adequate, and we were not helping our patients to get better and to survive. And I took from that actually the major difference between us and the successful countries was that they were taking the acute phase of stroke seriously. The South London Stroke Register was established by Charles about 17 years ago and has continued to collect data ever since, a population-based register collecting data on all stroke patients that happen within this area of South London, collecting information at the time of the stroke and then following the patients up every year. And so we've got data right up to 17 years now. And that's been an incredibly powerful tool. There are very few other similar registers, certainly in the United Kingdom, and very few in the world, in fact. And none, I think, which have carried on for quite as long as that. And there's been some extremely good quality research that's come out of that with registrars and others who've come in and worked with us on the register. Judy Stewart was the first registrar that we appointed, and she really got the initial register going in many ways. Unfortunately, she died very shortly after this paper was published in the BMJ from metastatic breast cancer. What she showed was that there was a clear difference in incidence between the black population in South London and the Caucasian population. Twice the likelihood, if you're black, of having a stroke compared to being white. In other words, put another way, the black population were having their strokes about 10 years earlier than the Caucasian population. We've been able to study the trends in stroke incidence by ethnicity and age over a period between 1995 and 2010, so 15 years. We know, of course, the major risk factor for stroke is age, so the oldest patients have by far the highest incidence, and these are younger patients. All groups have shown a reduction in the incidence, so we're doing something right. A very significant reduction in incidence over that 15-year period. And that's been particularly evident in the black female population. And these data are a rather busy slide, but the figures highlighted in red are the figures for the total stroke incidence and the trend and reduction in incidence in the black women, down by about a half overall, but particularly for hemorrhagic stroke. And the major risk factor for hemorrhage is management of hypertension, and although we need to prove it, it seems likely that this reduction in incidence is due to better prevention and better management of hypertension in this particular ethnic group. Not only has incidence come down over time, but this slide shows, again, data from the South London Register, how survival has improved over time. So the bottom red line shows the survival curve for people recruited into the register between 1995 and 1998. And the top blue dotted line is the cohort recruited between 2007 and 2010. And so the survival probability in that early population looks as though it's much worse than the more recent population. And again, I think that the likelihood is that that has got better because our acute treatment has improved. We've got people into stroke units earlier and taken their acute stroke more seriously. I'm highlighting just a few areas of acute stroke research: deep venous thrombosis, dehydration and stroke, and a project that's recently been completed on looking at decision-making for people about to be given thrombolysis. So deep venous thrombosis is a very interesting condition in stroke. It's a very common problem. It's a major cause of disability and death after stroke. And unfortunately, it's very often first diagnosed when the patient collapses on the toilet and stops breathing and dies as a result of a pulmonary embolism. So what James Kelly did, who was a registrar who worked with us, was to use a new imaging technique called direct thrombus imaging to show DVTs. And it's a very sensitive technique, much better than anything that was there before. So here on the left is a picture of somebody's legs, it's the left leg and the right leg. And I think even I could see that there was clearly an abnormality in that right leg with a long, extensive thrombus in the proximal vein. And you can use the technique as well, an MR scan on the chest, and you can see that there's a large thrombus in the right pulmonary artery. And what he showed, screening 100 consecutive stroke patients coming through the stroke unit at St Thomas's, was that the incidence of venous thromboembolism was much higher than we had previously known. So all examples of venous thromboembolism in about 40% of the total population. Now, not all of those were significant. Some of them were small clots in the lower leg, which are probably not important. But 18% of the patients, so nearly 1 in 5, had proximal venous thrombosis, and that's a major risk for pulmonary embolism, and 12% of the patients had pulmonary embolism. And in patients with paralyzed legs, so with severe strokes, that risk of venous thromboembolism went up to about 2/3. And only a few percentage of those patients were actually identified before the scanning as having thromboembolism. So an important piece of research which has then gone on and led to some major trials which have been done out of Edinburgh, which we've been involved with here as well, testing various ways of preventing DVT. We still don't have the final answer. A.J. Balla was a registrar working with us and did his MD with us, and then went away and became a consultant in St Heliers in South London, but has come back a few years ago and is now a consultant colleague of mine with the stroke service at St Thomas's. So he looked, for as part of his MD, at the effects of hydration on stroke. He wanted to know how common it was that patients were actually becoming dehydrated. And you might be appalled to think that any patient coming into hospital could possibly end up dehydrated. But of course they can. The patients often have difficulty swallowing. The patients often have lost vision on the right side or the left side. And you see patients being sat in general medical wards, certainly at the time this study was being done, with their glass of water in their hemianopic field, so they couldn't see it, just out of reach of their paralyzed arm. And it's not surprising that they became dehydrated. And that's indeed what he found. A lot of people were admitted with dehydration. A lot of people became dehydrated during their stay. And if you were dehydrated, even adjusting for the severity of the stroke, the likelihood of you dying was very significantly greater. And those findings have been confirmed in some data that we've just looked at. Ben Bray, who's a research quality improvement fellow at the College of Physicians and at King's, has collected these data, and they were published in the BMJ a couple of weeks ago. About 30,000 patients are put into an audit that we've been running of acute care across the country. And what we do in that audit is people have to complete, were certain things done, were certain processes completed during the course of that patient's stay. And most of these patients actually were on stroke units. But despite that, a lot of people on these stroke units were not actually seen initially by a stroke consultant. And a lot of people, if you look down at the bottom here, bundle 4, a group of standards that people had to achieve, were they given an antiplatelet therapy, were they hydrated, and were they nourished in the first 72 hours. And what you can see from these data is that actually, very surprisingly, I don't really believe it, but seeing a stroke consultant within 24 hours of admission actually seems to be beneficial. But more importantly, if the hydration and the nutrition was taken seriously, it had a huge impact on the survival of that patient. Now, I think that we need to do more research on this, but my view is that this is a key area that we need to address in terms of quality of care that's likely to have a major impact on mortality. This is a picture of Jill Clucky, who is our stroke specialist nurse who took 3 years out to do a PhD. And she participated in the opening ceremony of the Olympics. And this is her uniform for that event. Again, I yearn for the days when everyone was dressed like that, the nursing staff. And what she was attempting to do was to look and see what information was conveyed to stroke patients who were in the emergency department and who were about to be given clot-busting treatment. A treatment which is potentially very dangerous. It can kill up to 5% of the patients you give it to, but has also major benefits as well. So she did an observational study, an ethnographic study, looking at what actually went on in 4 hyperacute stroke units in London. And she's just submitting her PhD on this. And those of you who are interested will be able to read it in due course. But the 2 key things that I think she found was firstly that the patients were rarely actually able to recollect afterwards what was said to them. and those that had a view felt actually that they wanted the clinicians to make the decision for them, which is a little bit against what organisations like the Stroke Association might actually be arguing we should be doing. So I think we can probably just go on and do what we like to patients. Rehabilitation research, we've done quite a lot on, and I'm going to talk about three particular aspects: predicting recovery, longer-term outcomes, and early supported discharge. So Kate Tilling was a statistician that worked with us 10 or 15 years ago, and what she wanted to do was to look to see if it was possible to predict the recovery of patients with any degree of certainty. Most of you probably will be aware of the growth curves that children are measured against. When you take your child to the health visitor, they'll be weighed and measured, and then the clinician will look at the graph and see if they're following the trajectory which would have been predicted if they were growing normally. And that is a very useful technique for picking up people, children who have developing abnormalities or being malnourished or whatever. So could we use the same thing in stroke? And she developed a set of curves which do look as though it could be a very useful tool, and that research is now being taken forward by Justin Grace, who's working with us at the moment, to see if we can produce a model where we could actually provide the clinicians treating a patient on the ward with a stroke with a clear description of what should happen to that patient, and to see whether or not we are able to pick up earlier than normally the sorts of things which might be delaying recovery, such as the patient becoming depressed or developing an infection. Some of the longer-term outcomes after stroke really have not been well studied, but yet they're often devastating for patients. And Mehul Patel, who's a stroke physician down in Lewisham, did his MD with us, and one of the things he looked at was urinary incontinence. So he looked at 324 patients who had been admitted with incontinence or had incontinence at a week after stroke, and then followed them up for a 4-year period. We knew that incontinence was a major predictor of poor outcome and death. And indeed, 105 of those patients were dead by 3 months. 80 of them were still incontinent, and 15% were still incontinent at a year. Now, this is a problem following stroke which is really debilitating, it's embarrassing, it's something which people find really very hard to live with, and often results in people becoming very isolated, not wanting to go out, and so on. And it's something which we probably could do very much better at. And we need to do more research to find out what actually the pattern of recovery is, why people remain incontinent, and what we can do about it. And a similar sort of problem, which often gets overlooked after stroke, because we don't really know how to treat it effectively, we don't really even know how to measure it effectively, is depression and anxiety. And Lewis has been working with us and has submitted his PhD on looking at the long-term impact in terms of emotional outcomes that stroke has. And what he's found is that over half of the patients develop a significant depression at some stage after their stroke, that many of those episodes of depression are present within the first 3 months, but people recover and then get worse again, become more depressed again, and there's a pattern, a cyclical pattern. And I think it's been important research in terms of showing us that we cannot accept that patients are stable, that we cannot afford to discharge people without having some system for being able to help identify their problems in the longer term. And that was reinforced by Charles Wolfe's paper in PLOS Medicine, looking at outcomes up to 10 years after stroke in terms of a whole range of different functions. So these are little graphs showing the Bartel Index, which is a measure of physical disability, largely depression, cognitive, mental domain of functioning and physical and so on, anxiety, cognition. And while the pattern of disability appears to flatten out over time, there is considerable variation. There are people who are getting worse quite late into their stroke. And we have got written into the National Stroke Strategy that people should be reassessed at a year and then yearly thereafter after their stroke. And that is really clearly important if we're going to tackle some of the problems that Charles identified in this paper. We conducted here in South London one of the very first trials, and certainly the largest trial that's ever been done on early supported discharge after stroke. Helen Rogers, who's sitting up at the back, who's a stroke physician in Newcastle, ran a smaller trial, slightly differently designed up at the same time in Newcastle. But this was really the first large-scale trial, and the hypothesis was that we were keeping people in hospital far too long, that people were more likely to recover better if they were being rehabilitated in their own home environment, that teaching people to get on and off a hospital bed, teaching people to use a hospital toilet is not really very much use, and it would be far better to do it in their own homes. So what we set up was a trial where we compared conventional treatment on the stroke unit and then home to normal treatment with an intervention where people were discharged as soon as they were able to be safely managed at home, and then to receive the equivalent of stroke unit care, physiotherapy, occupational therapy, speech therapy in their own homes for up to 6 weeks. And that trial was then subsequently replicated in many other trials, and all the data were put together. What we showed in our initial trial was there didn't appear to be a huge difference in outcomes between the two groups, but it was an intervention which was the patients quite liked, and it was cost effective, and it was actually a cheaper way of delivering care, and it certainly didn't appear to produce any worse results. When all the results of the trials over the subsequent years were put together, and this is a Cochrane review, and again, anything over to the left-hand side of this vertical line, in terms of these little diamonds, is a significantly beneficial treatment. It favors the intervention. If you looked at the outcomes in terms of death and dependency, they were better in the group that received the early supported discharge. And as a consequence of that trial, there has been a major shift in this country in the way that we are delivering stroke care for patients now. It is now recommended as part of routine care by the National Clinical Guidelines, by NICE guidelines, by the National Stroke Strategy, that all patients should have access to early supported discharge. We haven't achieved it yet. Only 2/3 of hospitals have access to these teams to discharge the patients to, but it's getting better, and we've got the evidence base, and it's certainly something which I think we will see a growth in that sector in due course. Niall McLean was another researcher who came and worked with us. He was a philosopher. And we wanted to explore the whole concept of motivation after stroke. Any of you who have been involved with stroke patients will, I'm sure, have come across the situation where people talk about patients as being unmotivated or motivated. And we were keen to find out what actually that meant. And so he did a qualitative study, interviewed a lot of patients, both in the group who were labelled as unmotivated by the therapists, the nurses and the doctors, and those who were highly motivated. And what he found was that all the patients he interviewed thought the rehabilitation was important. But the highly motivated patients were much more likely to view rehabilitation as being their way of being able to make a recovery. These patients, the highly motivated ones, were more likely to understand their own role and what they could actually do about it, and to understand the role of the professionals. And those views in those highly motivated patients were actually reinforced often by the views of the therapists who would reinforce those beliefs, and that would further help those patients to become positive about rehabilitation. The converse were the patients who were labelled as unmotivated. Actually, what that really meant was that the patient's views about what they wanted for the future didn't match the therapist's views. But certainly, there were some common features in that group. They were patients who were often overprotected by family members who would come in and feed them rather than allowing the patients to feed themselves. The patients were often not given very much information, and they were reinforced by unfavourable comparisons with other patients and so on. So that, again, is I think, an important bit of research in terms of helping to guide us in terms of what we do with a whole broad spectrum of patients that we have to deal with. Stroke prevention research, we've looked at the prevalence of risk factors by ethnic group, and what this has shown is that there are very big differences between the black population and the white population in South London in terms of many of the risk factors for stroke. Hypertension much commoner in the black population, smoking much commoner in the Caucasian population, atrial fibrillation much commoner in the Caucasian population, and so on. And the message from this research, I think, is that we cannot assume that the entire stroke population and the entire population at risk of stroke are the same. They need to be targeted in terms of health promotion in different ways, specific to the particular risk factors and ethnic group that they're in. But what we know is that our ability to persuade patients to comply with secondary prevention measures, our ability to persuade physicians to prescribe the appropriate secondary prevention measures to prevent further strokes really is not very effective. And too many people come back into hospital with a second or third stroke, still not having their blood pressure controlled or still not taking their antiplatelet treatments. So Jude Redfern and Charles and others ran this cluster randomized controlled trial in South London, aiming to see whether giving personalized information to patients precisely related to what risk factors they had, what the benefits of treatment were or behavioral risk factor adjustment were. And that was given at the time of discharge and then at 3 months later. And those patients' GPs were also given personalized information about those patients with all the evidence from the guidelines. And those patients with all that extra information were compared to standard care. And the main outcomes we were looking at was the use of anti-blood hypertensive treatment, so blood pressure treatment, smoking cessation, and the use of aspirin. The results showed that absolutely no effect whatsoever. So many years of work for a negative trial. So back to the drawing board, but still probably an important study to do. So implementing the evidence, we know certain things clearly work. That it is totally unacceptable, I think, in this day and age, for patients not to be admitted to a stroke unit for specialist care and rehabilitation. It's the biggest, single most important thing that we can do to reduce mortality and morbidity. We know that thrombolysis, clot-busting treatment for stroke, is beneficial for some patients, probably about 20% of the stroke population. I've shown you the data already about early supported discharge and getting people out of hospital to equivalent of stroke unit care in the community. And there are lots of interventions around prevention that we can provide which will reduce the risk of recurrent stroke. So how are we doing in terms of delivering those things? Well, Codman back in 1917 was a physician who wrote this, that every hospital should follow every patient it treats long enough to determine whether or not the treatment was successful and to inquire, if not, why not, with a view to preventing similar failures in the future. This is nearly 100 years before the Mid-Staffs inquiry and the scandal that we've just been hearing about, where it's exactly this failure to monitor the patients and to take the outcomes of their patients seriously and to inquire why their patients were dying more frequently than they should have been. That's we still were not doing. Now in stroke, I think we've done quite well, and we'll come to that in a minute. But I just wanted to take a slight detour into stroke thrombolysis because for the non-clinicians amongst the audience, this is perhaps the sort of the sexy end of stroke care, the thing which actually is important, the thing which you're told about with the FAST campaign advertisements that the Stroke Association and the Department of Health have been leading, getting you into hospital as quickly as possible. And the trials of thrombolysis show that actually it doesn't save lives, but what it does is if you do survive, you're much more likely to survive with less disability. So the patients in the groups in the trials that did not receive clot-busting treatment, there was a 30% chance that they'd be alive and independent at 3 months, whereas a group that had the treatment had a 44% chance of being alive and independent. So a 14% improvement in terms of the chances of being alive and independent. So a major impact. So just to illustrate how effective the treatment can be, this was a 78-year-old retired professor of history. He's been having lunch with a friend and suddenly developed a right hemiplegia and a severe dysphagia, so unable to say anything actually. And he arrived about 45 minutes, I can't do my arithmetic, 35 minutes later, and at that stage he was unable to see anything over to the right-hand side. He had a complete paralysis. He'd completely lost all sensation down his right side. He couldn't actually even recognize his own arm as belonging to him. So a very profound stroke. He had a brain scan done within a few minutes of coming in. Essentially, it's normal, it's a bit atrophic, but then he was only a professor of history, not medicine. and he received thrombolysis about half an hour after coming into A&E, and within a couple of hours he was already very much better. Within 4 days he was out of hospital, completely fit and well, as if nothing had happened to him, and his follow-up scan was unchanged. So that's really what we've got to aim to be delivering for our patients acutely. Really high quality emergency care as quickly as possible. Now, back in 1995, I had a phone call from Dr. Anthony Hopkins, who was the leader of the research unit at the College of Physicians. I could not find a photograph of Anthony Hopkins anywhere, but I found this one. So I thought I'd use it anyway. So he invited me along to a meeting that he'd set up to discuss commissioning of stroke care. And there was no such thing as commissioning specifically for stroke in those days. It was all part of general medicine. So he was visionary, really, in terms of recognizing that if we address stroke specifically and develop services specifically around it, that might be beneficial. And then, having arrived at that meeting, I then discovered at the end of the meeting that I'd been nominated to chair a committee at the Department of Health to develop stroke outcomes. But anyway, so that was the beginning of a long association that I've had with the College of Physicians. Shortly after that, Penny Irwin, who's delighted to see here today, was appointed to manage the program, the stroke program at the College of Physicians. And about 12 years ago, Alex Hoffman, who's in the middle here, took over from her and has led that program since, and Sarah Kavanagh and James Campbell are two of the members of the team. We've got a fantastic team there, and I've got 3 associate directors who work with me as well. And it's been an enormously successful program in many ways. We've developed the first guidelines for stroke in this country. They first came out in the year 2000, and we've produced new editions every 4 years. We've run national audit for stroke, and I'll tell you a little bit more about that, for stroke and carotid surgery. And then we've had a quality improvement program helping trusts, hospitals, clinicians to improve the quality of care, and at the same time to lobby both politically and to the managers and commissioners of healthcare that stroke is important. And here are some of the other members of the team, who I won't name individually, but they know themselves, hopefully. So these are some of the early stroke audit results from back in 1998, just to show how bad it was. So only 18%, so less than 1 in 5 patients were treated on a stroke unit at any time during their stay. Only a quarter of patients had any evidence in their notes that people had even considered that there might be cognitive impairment. Less than half had any evidence to check whether their visual fields have been tested. We've continued to run national audits since then. We've had 100% participation for the last 10 years nearly. We've produced public reports long before the present government decided that was something that was important. We've been doing that since 2004. We've produced reports for the individual clinicians and hospitals, comparing their outcomes of care and their processes of care to the national averages. We've used the data to inform the National Audit Office, who produced a really important report on stroke care, and to inform the National Stroke Strategy. And we always go out and try and get as much media attention as possible, because one of the problems of stroke is that it's a disease which, frankly, the public and the media have not really been interested in. And negative publicity has been very powerful. So just one example, there was a clinician working in a rural part of England who had been appointed 5 years before, who had been desperately trying to get better quality services for her patients. Not very much happened. She had the results back. The BBC radio station locally got her into the studio. I was up on the London end giving the national picture. She had a bit of a hard time, this poor girl. Why was there such delays to get scanning? Why weren't patients being treated on stroke units? She got back to the hospital feeling somewhat wounded. The chief executive had already convened a meeting in his office with the medical director of radiology and medical director for medicine, and within half an hour she had everything which she'd been striving to get for the previous 5 years. The audit has been useful in showing up some of the other sort of deficits in stroke. So this graph shows one example of the effect of coming in at weekends, so out of normal working hours, and the effect of being old versus young in terms of the processes of care. So do you get a brain scan? If you're under 65, you're likely to get your brain scan within 24 hours. This is some time ago. We've got a lot better than this since, I promise you. If you're over 85, within 24 hours, much less likely. And if you come in at weekends, much less likely to get decent care than if you come in Monday to Friday, 9 to 5. Unfortunately, no one's told the stroke disease yet that it has to happen during normal working hours. We also heard, well, we can't do brain scans on these patients. We don't have enough scanning time. We don't have enough scanners. And this graph shows the nonsense that that statement represents. This is the time of day that the scanner was used to scan patients with stroke. Nearly all the patients had their scans during the day, apart from at lunchtime when it looked as though some units closed down, and the scanner lay idle during the night. Okay? There's no reason why the health service should be operating Monday to Friday, 9 to 5. We should be using its resources 24 hours a day, 7 days a week. And these data from James Campbell at the college, again, looking at the data from about 30,000 patients put into our acute stroke audit, again shows a comparison of the quality of care for people being treated, and this is within the last 2 or 3 years, who arrive in normal hours or out of hours, and anything over to the left-hand side of that red line shows that the patients are more likely to receive those things if they're in hours and out of hours. So what the message from this slide is a bit complicated, is that actually, again, you are much less likely to get good quality care if you arrive at inconvenient hours. We've looked at the data to see if the size of a unit makes a difference to the quality of care. And this is interesting data, as I'll come to in a bit when we talk about London. But what this shows is that units which are treating relatively few patients with clot-busting treatments take almost twice as long to give the treatment after the patient arrives at the front door to the units which are treating larger numbers of patients. So bigger does seem to be better and more efficient. And over the years that we've been running the audit, we've seen major changes. The number of people who are being thrombolyzed between 2006 and 2010 has gone up. The number of hospitals offering the service has gone up. The provision of services for people with mini-strokes, which need to be treated as an emergency, has also improved dramatically, and the waiting time has come down a great deal. Institutionalization rate ending up in a nursing home has come down. 30-day mortality over time has also come down from about 24% in 2004 down to about 17% in 2010. So very significant reductions in outcome. But despite all those improvements, despite being provided with data around the quality of care, we were still not doing brilliantly. And in London, Ruth Carnell, who was again in the audience, the chief executive of NHS London, made a decision that this was unacceptable, that these hospitals, each of these bars represents a hospital. And the bars in red, so the hospitals in red, are those who haven't achieved the sort of 90% on the audit, which you or I would want to be treated in, so a hospital that scores highly. Some of these hospitals, over on the right-hand side, were scoring extremely low on the audit. They were places where you would not even want your mother-in-law treated. And what was even worse was that some of these hospitals, if you compared the outcomes between 2004 and 2006, appeared to be getting worse. So major inequalities in terms of the provision of stroke care. The good hospitals, and I mean modesty prevents me from saying which one of those St Thomas's is, but the good hospitals centred in the centre of London largely, and the poorer hospitals around the outside. But if you then have a map showing where most of the stroke patients live, they're living around in the suburbs where the older patients tend to live in London. So we had a situation where we had some extremely good hospitals in the centre of London with no patients to treat, and some poorer hospitals around the outside with masses of patients. So we had to do something about it, and that's what Ruth decided she was going to do, and as a result of her work, that's what happened. She persuaded the primary care trusts to invest extra money in stroke care to be paid if those hospitals treating the stroke patients delivered high quality care. The decision was made to centralise the first 3 days of care into just 8 units in London, geographically spread so that they were close to where the patients lived. The decision was made that we would admit all stroke patients into one of these hyperacute units, not just those who might be eligible for clot-busting treatment. And then after 3 days, if the patient couldn't go home, they would go on to a stroke unit again with high-quality care, much higher than before. And the outcomes are that we've increased the rate of people receiving clot-busting treatment from 3.8% before we implemented the changes to 19% in the first quarter of this year, which is higher, I think, than any other big city in the world. The survival from stroke in London appears to be significantly better than the rest of the country. And I believe that that is due to the fact that we're providing better quality care. And Steve Morris, a health economist at University College Hospital, did a health economics evaluation of the study. And again, I'm not expecting you to interpret these data in the time that I'm going to give you to do it. But the bottom line is that despite investing extra money in the stroke care, the costs in the end were less, and they were saving lives. So we were saving lives, reducing disability at lower cost. And the cost was lower because people were not ending up in intensive care, people were not ending up in nursing home care. And this intervention won one of the BMJ awards. I can't remember which one, but something anyway. So I just want to finish now in the last couple of minutes with some of the work that I've sort of been a bit peripherally involved with elsewhere, because I think some of the lessons that we've learned in the UK and elsewhere in Europe really do have resonance elsewhere. And I want to start off in St. Petersburg, where Pauline Munro has been working for many years, since before she retired as a neurologist from Atkinson Morley, and I'm again delighted to see her in the audience today. And she has, over the years, organised multiple visits of clinicians coming from Russia to London or to England, and return visits from clinicians going to Russia, and I've been the lucky recipient of a number of those trips to try and improve stroke care and get the idea that effective multidisciplinary working is worthwhile. And this is where she started, really. The ward on the left-hand side, treating some stroke patients in one of the hospitals, no privacy for the patients, the mattresses as thin as anything. Walking into the ward, there was the smell of rotting flesh from pressure sores, incontinence and dirty bodies, quite revolting. And the patients lay there getting problems with their airways blocking off from dried secretions in their mouths. At least they had private toilets under each bed. And if they wanted to get to the rehabilitation department, which there was a rehabilitation department, there's this 45-degree ramp which precluded anybody really from getting up there to receive it. Once they got to the rehabilitation department, the sorts of treatments that they received were things which we do not recognize here as necessarily being effective. I'm not saying that they are definitely ineffective, but some of them do stretch credibility somewhat. So lots of electricity supplied, lots of wax baths. And this one, putting your mouth around a little plastic tube that sticks out of a machine that produces ultraviolet light. And it's a very cost-effective machine because you've got 3 pipes sticking out, so you can treat 3 patients at once. And that apparently helps the stroke get better as well. So patients would be admitted for a fixed period of time, regardless of stroke severity. They'd be in bed for most of that time. They'd have lots of injections. They'd only have rehabilitation centres. We visited one near Kazan, where the bedroom was upstairs with no lift. And they could only cope with people who were continent and mobile. So not really the people who really needed the rehabilitation. The nurses were entirely taught by doctors and subservient to doctors. Now, this isn't necessarily a bad thing. I don't think we necessarily need to criticize everything. They were working 24-hour shifts. The nursing and the pay for doctors was extremely low, and most of the care was actually provided by relatives. And she collected equipment and all sorts of things, arranged to have it shipped out to Russia. And this is a stroke unit that was set up at the Pavlos Hospital, really replicating in many respects typical stroke unit care in the United Kingdom. So a major triumph, I think, and I congratulate her. In China, there's been a new project which NICE International has been involved in, and Calypso Chalkido is leading on that project. But it's a really important topic. I showed you the map earlier on showing the causes of death being the second commonest in China. Actually, in China, it's almost the first. Over 2 million cases a year, about 4 a minute. Many more hemorrhages in China than infarcts than in the UK. 20,000 hospitals treating stroke patients. Lots of treatments being used which are sort of unproven. And lots of things that do work but not used very often. So virtually no stroke units, no conventional rehabilitation, and very little in the way of primary and secondary prevention. Very high rates of smoking, including 60% of the doctors smoke in China. And if you do the maths, actually, and this is just back of envelope stuff, if you introduce stroke units into the Chinese health system and they were as effective in China as they have been shown in the randomized controlled trials, you'd save about 100,000 lives a year. Effective blood pressure treatment control would save at least 500,000 lives. So there's been a project which has been initiated by NICE International and the Chinese government that I'm involved in to look at a project to implement payment reform and evidence-based pathways into the rural population. We had a trip out there in 2011 and then launched the major project last November, and I'm off out to China again in a couple of weeks' time. And in the front row, you can just see Calypso there, the short one. So I want to thank everybody who I've been working with over many years. I've achieved absolutely nothing without the assistance of others. And there are many people that I've worked with who I haven't mentioned this evening. I particularly want to thank my family. Here's a picture of them back in 1989, my wife and Daniel, Alistair, Ian and Claire. Of course, they don't stay as sweet as that for very long. And here they are on a walk a few years later. Alistair is now a policeman with the Met. Daniel is a doctor working at St. George's at the moment. My daughter is now a chemistry teacher at Epsom College, wasn't allowed out by the headmaster because it's parents' evening tonight. But she still remains as cheerful as she looks there. Every family, of course, has a black sheep. And in our case, that's Ian. He had a first-class education. He went to an excellent medical school in Cardiff, qualified as a doctor, and he's now thrown it all in and is training to become a surgeon. Most of all, I want to thank Lynn, who's put up with me for the last 33 years. Thank you very much.
Ladies and gentlemen, I now call on Professor Charles Wolfe, Head of Division, to give the vote of thanks.
Thank you, Anne, and thank you very much to Tony Rudd for the lecture. And it falls on me to propose a vote of thanks. And I think I'm sure you've all found the last hour very, very interesting in terms of truncating 25 years, well, 25 or 55, depending on who you believe years' work into an hour. And I think what I reflected on was, it's bad enough getting up to do the day job of doing research, but this is an element of a clinician who's been embedded within a dry research laboratory, not Sir Robert's immunology laboratory. I've reflected that, so it's been a great pleasure for me to have that privilege. But to then also do the health service research, the sociology, the epidemiology, and the trials, but then also to start implementing it, what they now call implementation science or improvement science. I was just thinking while you were talking about what that really means, and I think it means you're not so much of a control freak as, or you're more of a control freak than it comes across as, because in fact, to do that, leadership's really important. And apart from doing the research, you seem to have been president of a group that then looks at the standards for the doctors you wish to work in a certain way. And then you chair the guidelines that determine what the evidence will be. And then you audit that through the college, so you audit what you've determined will be the guidelines. And then you go and see Ruth Carnell and get the funding to do what you want to do. So there's obviously some charm in there as well. But the important thing is, which many of us don't do as clinician scientists, is to actually take it right from the beginning in terms of the hypothesis and the question, and then driving that through and really showing within a year or two of these big transformations in a global capital like London that you can save lives. So I think that's really very important, and it's down to the mixed methods approach that has been important. I think the other thing is that 25 years, perhaps you've chosen the right 25 years. As an epidemiologist, I might say if you took another 25 years, it would have been a flat line. But certainly, when I started in at exactly the same year as you, having been a gynecologist, I was told I had to do something different and work on stroke. So I went to Sir Richard Thompson, who's now president of the College of Physicians, and proposed to do a study. Apart from being asked what the definition of stroke was, he said, good luck, I'm not sure where all these stroke patients are. And I went to see Finbar Martin, who I'm not sure if he's in the audience or not, who was very supportive, but really wasn't sure. And then Tony was, I think it was the first day he was there, decided that was an important topic. And so for the last 25 years, we've tried to work on that. So I think that the lecture has really been underpinned by the science, but really the implementation of that evidence in the most effective way, I think, has been really a very impressive lecture, and thank you very much indeed. So a round of applause for Tony.
Ladies and gentlemen, I am sure you'll agree with me, we've had a superb inaugural lecture. Please join us in the celebration at the reception in the foyer. Thank you very much.